it's okay to tell someone, this is a lot. I'm feeling a lot right now, and I just think that I need someone to talk to about that. And it's not a sign that you're not doing a good job being a caregiver. I think it's the opposite. I think it's taking care of yourself to make sure that you can continue to be a good caregiver, and it's needed.
Welcome to Some Stutter Law, Newfoundland and Labrador's first podcast about living with communication disorders. It is a production of the Communication Collaborative. My name is Greg O'Grady, and I am a person who stutters and your host. Some Stutter Law aims to rebuild confidence and hope for people who live with communication differences by dismantling myths, stigma, stereotypes, and barriers. For more information about the Communication Collaborative or this podcast, you can find us at somestutterlaw.ca. If you only get one thing from this podcast, we hope it's this. It's okay to stutter and it's okay to communicate differently. It's not how we communicate that's important, it's the message that's important. Today, Some Stutter Law welcomes Dr. Samantha Shune and Michele Vandehey. Dr. Samantha Shune is an associate professor and the director of the Communication Disorders and Sciences program at the University of Oregon. Prior to returning to school for her PhD and throughout her doctorate program, she worked as a speech-language pathologist across a number of healthcare settings. Her primary area of interest is dysphagia, particularly in terms of exploring the impact of disruptions to the eating and swallowing process on the individual and their family system. Michele Vandehey is a clinical supervisor for graduate student clinicians at the University of Oregon in the Brain Injury and Concussion Clinic. Michele also continues to work in the medical setting, specifically acute care and inpatient rehabilitation as a medical speech-language pathologist. She completed her coursework and thesis in dysphagia at Idaho State University. She is also the daughter of a stroke survivor who experienced severe dysphagia and cognitive communication deficits, who she provided support to within the home and community for nearly 20 years. Her clinical and research interests primarily center around identifying dysphagia and its impact on individuals and their families, including how to foster improved functional outcomes. So, welcome Dr. Shune and Michele to Some Stutter Law today.
Thank you for having us.
You're welcome. First question, Doctor, is what is dysphagia?
Yeah, great question to start with. So dysphagia most broadly is difficulty swallowing or an impairment in swallowing. And I like to include when I talk about what dysphagia is, that it can come from a number of different issues. So it could come from difficulty with the motoric actions of swallowing. It could come from a sensory deficit. It can result from a cognitive deficit as well. And so there's a lot of contributors to dysphagia.
Looking at the umbrella of communication disorders, we have speech disorders, speech delay, and then we have language disorders, and then we have feeding and swallowing dysphagia falls under communication disorders. For our listeners who are wondering, why would dysphagia fall under communication disorders?
Yeah, I can respond to that first. The first thing that I always tell students, because this comes up, I mean, pretty much day one when we're introducing students to the field of speech language pathology. And I like to point out that to speak, to communicate, we need to use and learn about our lungs. We need to learn about and be using our throat and our larynx and all the structures in our laryngeal framework here. We're using our mouth and our teeth and our tongue. We're using our nasal cavity. And isn't it fascinating that those are all the exact same things that we use when it comes to swallowing? And so who better then to handle swallowing and feeding disorders than the individuals who are experts on those pieces of our body and how they move. And so that's the first thing that I always say, that we are the experts in those structures. And so it makes sense that it'll carry over to feeding and swallowing as well. I think the other piece, and perhaps this is my bias when it comes to talking about dysphagia and swallowing disorders, is I think they're intricately linked. I mean, we eat in the context of social interaction. We're engaged in communication while we're eating. And so again, I think food is just such a part of that communication and socialization process. So I know that's not the primary reason, but I like to bring that up too, that there really is a link between communication and eating and swallowing.
Thank you. Thank you. How does age of onset of dysphagia affect the caregiver experience? Now, one of the reasons why I'm asking this question is in a past life, I had worked for 30 odd years within a long-term care facility, and so we used to be asked to do help up during meal periods, and I was often assigned the dysphasic residents to feed, and but this is feeding through mouth, okay, so they weren't on a tube, and to be honest with you, I felt very uncomfortable. However, there was always registered staff around, of course. But you see, so I always associated dysphagia with seniors. Okay, so the age of onset, what's I mean, I'm sure it has so many issues, like as Michele was saying, the grieving, the shock value, and just how what effect does it have on the care recipient and the caregiver? There's a $64 question here.
A lot packed into that question there. I think
It is.
I can start and offer some thoughts and then let Michele chime in. I mean, first, we do know that the risk of dysphagia increases into older adulthood. And so you're right, having that association between older adults and dysphagia is a legitimate thing. We do see that risk increases as folks get older. I think if we're talking about someone living at home, that can be harder, especially if they're living with a spouse who's also aging and who also might have issues associated with age. Maybe they have some decreased manual dexterity. Maybe they have some decreased memory going on, these kind of typical changes that we see with age. Maybe they have something more severe. Maybe they had a stroke 2 years ago, but now compared to their loved one that they're taking care of, they're actually doing better. And so I think we just see more of that in older adulthood, that it can become a much more complicated picture because we also often have a caregiver who's an older adult as well. I think the other thing that I'll throw out there is kind of food for thought is, and again, I'm looking through the lens of, I live in the United States, so kind of that American strive for independence, really, really be independent. When someone is perhaps a younger adult, it could be a more dramatic impact on their life because they're so fiercely independent. And so when something goes wrong and suddenly they do have to be dependent on someone else, so for example, be fed by someone else, that can really severely negative impact their self-esteem, their self-worth. It's a mismatch between seeing themselves as, I've made it, I'm an adult, I'm doing things on my own, and now I have to rely on someone else for care. Whereas I think when we think about older adulthood, it's often more okay to ask for help to some degree. And so, from the perspective of the patient or the client, it sometimes can be harder to go through that grief process and to adjust if you are younger and something happens, like you're in a car accident and suddenly need assistance with some of these activities of daily living. So, I don't know, Michele, what do you think?
I mean, age is one factor, but I mean, severity to me is really the main, I would say, the main factor. Just in the sense, while I also recognize plasticity in the brain wise, if someone has an accident when they're much younger, I would say their recovery outcomes, we often see that they make more strides than maybe an older and adult with the same injury. Um, However, I think, if you have a severe injury when you're younger, I think the potential for caregivers long term, um, I think there could be a huge impact. So, like in my family's case, my dad was 52 when he had his hemorrhagic stroke. Um, and I think for us, like we were really young kids. So for our family, it was a huge impact just in the sense that, he was otherwise relatively healthy. So he lived for a really long time. But the severity of his cognitive deficits were such that he would, things like radishes, he would put 5 or 6 in his mouth, just impulsive, really impulsive, right? And then he would choke, and then we'd be in the emergency room. So I think severity is actually more the question at hand.
Mm,
Um, what are your thoughts, Samantha, on that?
mm,
Yeah, no, I think that's a really good point, Michele, that you bring up, that we could have the exact same situation, same scenario, um, and that severity is going to be a big marker. And I think some of it is how you cope with that too. So, I think you mentioned that, alluded to that, is how is the whole family coping, and is it something that you're going to live with for a long time? Is it severe and you're living with it for a long time, versus something that you're recovering from more quickly? So
mm. Uh, Dr. Shune, you mentioned recovery. So do do some people recover from dysphagia?
yeah, certainly. Some individuals recover, and it's certainly not an all or nothing either. So folks can recover some of their lost function. Some individuals can recover all of their lost functioning, and other individuals may not. I think, as Michele said, some of it's going to depend on severity. Often, the more severe the impact, the harder it is, so to speak, to make a full recovery. It's also going to depend on what caused the dysphagia. So if we're looking at something like dementia, which is a degenerative condition, we wouldn't expect the swallow to improve. It might maintain for a while,
Mm-hmm.
but in all likelihood, it'll probably continue to decline over time. Whereas something like a stroke or traumatic brain injury, where we do see a lot of improvement just overall in the system and in the brain, then an individual might be more likely to regain some or all of their lost function.
Mm-hmm. You know, you know, I'm thinking now about the caregiver burnout. I'm sure it's a fine line, there's a fine balance of when a caregiver is so stressed out. So my question is, how does a caregiver access support from an external support agency for support? So Michele, when your family was caring for your father, I mean, there's such a long duration. Do you want to share some examples of any potential for burnout, or was there burnout?
Yeah, I think, my family's philosophy kind of became, that this is our new normal. And, we loved my dad very much. He was a very different person after his stroke. But, I think really the resilience that my mom fostered for our family made it so that we really didn't spend much time in the space of like, oh, this is too much. Like we viewed it more as he's our family member. I think now that he's passed, we've had time to process, kind of the burden on care partners. So for him, um, cognitively, again, kind of going back to that piece and how it ties into swallowing. Um, but he was in the emergency room several times, with his airway partially occluded with things from swallowing, and so my mom, there was a lot of burden there, just in terms of his care. He also was lost overnight a couple of times. Just like he knew where he was going, and then motorically just didn't make it, kind of thing. So like we were really rural. And yeah, so in his case there was other factors besides just the dysphagia. However, that alone was definitely its own um, challenge over time. And I think what's really interesting too to think about is kind of some of these other factors. So, initially when he was out of the hospital, he actually had a trach tube and a peg, or essentially a feeding tube in his stomach. And he couldn't eat at all. And we got to a point where he, was able to eat normal foods relatively safely, I would say. Um, but, then over a 20-year span, there's other medical issues that come into play too. So anytime he was in the hospital, it was like his swallow would revert back to being much more impaired, I think, because there was like some more burden on his own brain. So it was actually a really long journey in terms of, and the burnout piece, my goal, I guess, kind of going back to that, I would actually love for there to be mental health supports in the hospitals, so that when people go through events like this, like they have someone to talk to immediately. And Samantha and I've talked about this. I guess my dream would be that when patients go to their doctor's appointments and those things, that families actually have the opportunity to have counseling services like in the same building, so that they have the chance to take care of themselves in addition to taking care of their loved one. But I don't think we're
Mm,
there yet, at least in the United States. So,
mm. You know, that's a good, good point, because I'm sure that there's there you know there you know there you know there's a strong need for mental health support for the care recipient, as well as the care provider. So the doctor shown, like like are there any professionally trained you know, professionals out there to provide such a especially for mental health support? Because listening to, Michele, there's a huge need. So, like, is there any training, or do you depend on the SLP, or you know?
Yeah.
So would this be considered a gap, a strong gap that needs to be okay?
Yeah, I would say from a practical standpoint, there's a gap. There certainly are individuals who are trained, but I think there's a big disconnect between us recognizing that individuals need help and actually getting them the help they need. And so, speech pathologists, as part of the graduate training program, we certainly train our students in basic counseling level skills. That's part of the requirements, but that's not meant to take the place of a professional mental health professional. And so, we often teach our students some of the questions to ask. How do you open the door? How do you perhaps identify that someone might need help? And then, do you know who to refer them to? and how to refer them. And so different clinics are structured differently. And we're very lucky in our university clinic that we work here in interdisciplinary teams. So we have a couples and family therapy program here. And so we can kind of refer right over there. We can get those mental health professionals involved, but not every program works that way. And so when you're also talking about someone who is feeling burdened from everything that's going on in life, to hand them a slip of paper and say, oh, here's someone you could call to go talk to, well, that's just one more step for them to have to do. And odds are, that might be the last thing on their list. So I think that's where the big gap is how do we facilitate them getting to that person they need? So those individuals exist. How do we just work better as a team of professionals for getting these caregivers the help that they need?
Mm-hmm. I'm thinking now, Michele, in your case, what would happen if one of the family members, the caregivers, was in a mental health crisis? Have you ever been to felt you were at your wit's end? So in crisis situation, who would you have reached out to? I mean, it's great having an interdisciplinary team available, but in a crisis situation.
Just to clarify, do you mean us as a family? Like if my mom had been in a crisis situation?
Oh no, I mean just a family member, like your mother or yourself, because there's a lot of, there's a lot of stress involved in being a caregiver.
Yeah, so I think kind of depending on the level of care too. So in the hospital, we do have, well, I think the name is a little bit interesting, but spiritual care they call it, but often they have licensed counselors on staff, or we have crisis hotlines here that we would call. But I could identify that as a gap also, just because if a caregiver, is in crisis, and that's something to think about too in terms of processing what's going on. Is I do think there are times when we wait to give information to caregivers if they're in an active crisis, um, but definitely, we have supports there that could do something immediately, but long term, I don't feel like we have as many supports as maybe we could for caregivers, if that makes sense.
So is it like is this changing, or who's advocating for the support?
So
the government involvement or services?
I think in my case, I have made it part of my practice to try to discuss with families what I anticipate could be some of the challenges, having gone through it myself. So I know, in terms of like a micro level, I have made, the discussions about grief and loss kind of part of my education to families, and my recommendation to follow up with mental health supports, and, trying to kind of destigmatize that. Um, and then on a macro level, someday I would like to lobby with insurance companies and government agencies then, to, again, have it be kind of a required part of our care. Certainly you can always, at least here in the United States, like defer care and say like, no, I don't want that. But if it was more destigmatized and it was more readily available, I think there could be a lot of benefit. What do you think, Samantha?
Yeah, and I think because again, at least here in the United States, the focus of insurance, the focus of healthcare is always still on the person who's experiencing the medical condition themselves. And I think that is problematic with the structure of our system, because we are so driven by reimbursement. We're so driven by clinician productivity that it doesn't really give us the necessary space and time all the time to focus on the family, because simply insurance doesn't pay for that. So yeah, it's unfortunate.
The cost can be, I mean, the cost for caring for somebody at home can be, be very stressful. That can add to the stress of caring for a loved one. So who actually supports that? Who actually covers? Is there any subsidies? Or you mentioned that there's insurance, but I'm sure that can only go so far. And I'm just thinking that it will add an additional burden on the caregiver.
100%. And I think, I mean, funny is not the right word. I don't know what the word is I'm looking for here, but I know we cite all the time, at least the American healthcare system, they estimate that informal caregivers, so unpaid family member caregivers, actually saves the healthcare system about $480 billion annually by not having these individuals have to be in nursing homes, not having these individuals have to bring in paid caregivers. And so it's like, okay, what are we doing with those hundreds of billions of dollars? Shouldn't we be reinvesting some of that into then caring for these caregivers who are saving the healthcare system money? And so it certainly is a burden. And I think, if an individual has a need for a mental health professional and they justify it the way they need to, it could get covered through insurance, but that's a process. It's not just this automatic, like, wow, your family is dealing with the stroke recovery process right now. We recognize that the stroke recovery process is stressful, and so as part of kind of that stroke recovery package, that includes counseling or therapy for the entire family. That, I think, as Michele said, that would be the dream of how our model would look, but it doesn't. And so it does just increase burden of having to go, we as speech pathologists might recommend that they seek out services. They have to seek out those services. They have to make sure that their insurance will cover it. So it's just all these extra steps that don't recognize their value as human beings who are also, going through a really intense process right now.
I think too, the burden on caregivers can take a health toll. And I feel like, at least in the United States, healthcare, I don't think we're there yet in terms of prevention. We're starting, like, there's hints of it where, you might have like a weight management program that your insurance covers as a way, to try to be preventative. But I think that is an area that we could bolster, just in the sense that, caregivers have a lot of stress added to them typically. And, if we're able to get people support, it's less likely that their outcomes then, would be poor, would kind of be my assumption. But we're not there yet.
Yeah, we're very much a reactive healthcare system, even though preventative models would actually save money long term, but we are a very reactive system.
Is there any supports available, like in terms of community supports to bring in a healthcare provider into the home from a community agency, just to give the family a break? And if so, who pays for that? Is there an arrangement for somebody to come into the home to give your mother or a caregiver a break? Is that part of a gap?
I would say it's somewhat of a gap. It's challenging too, because, my family system, we felt as though we did what was best for my dad, in terms of bringing him home. And he had a pretty high level of independence, which was something we valued. But with that being said, you also can, well, scrutiny is a thing from others. Like, people were shocked that he was supposed to be on a different diet level at one time, and eventually we just allowed him to eat what he wanted, right? But if you looked at his medical paperwork, he should still be on thickened liquids. So I think honestly, in my family's case, I think there was a bit of a fear, that people wouldn't totally understand the choices we had made, and some of that
Mm,
comes from, so the couple of times that my dad was lost overnight, actually the state called my mom, and there was accusations, and I can, being in the healthcare system, I can say I don't actually think these were founded. Like there was no grounds behind it, but the state called my mom and had questions about negligence. um, so it's tough. So I think there's a barrier there in terms of having people come into your home. um, I think my family was really uncomfortable just because we sort of functioned, we were a decently oiled machine, I think, and we functioned as best we could. And dad really, thinking about that, really didn't like strangers. So it's like, we had caregivers for a while, but he was actually kind of awful to them. Because he really didn't want their help. He wanted to, he wanted to be independent and he wanted to do his own thing. So I think it was available. I also think, a lot of times with the caregiving process, it becomes part of your identity. So, my mom in later years, dad had a heart condition then, and started to kind of decline medically. But it was very much part of her identity then too, to care for him as best she could. And she was great at it, really. So they kind of became codependent in that way. So we didn't really ever seek outside supports. I tried, I know there are programs where you can have your loved one go to like a skilled nursing for a week and kind of get respite care. Um, but I know it's pretty expensive, resource wise. And I know, yeah, I think the cost
mm,
associated. And in our case, living in a rural area, it was really hard to find help. I mean, regardless of the other factors I just mentioned, but nobody wanted to drive the 40 miles from Portland, to come out to my parents' house, kind of in the middle of
mm,
nowhere. So there are
mm,
barriers, I think. There are, like I said, supports available, but I don't, um, they're kind of few and far between. At least that was our experience. But I don't know, Samantha, if you have other thoughts.
Yeah, and I think you're spot on for, if it fits for the individual family's circumstance, there are some supports available. I do think often you have to meet pretty specific qualification criteria
mm,
for it to be covered by insurance, for example. And so, a specific level of deficit or impairment, certain individuals, like if you're homebound, you can get your therapies in the home. So, that could be a good option for someone so that they don't have to drive their loved one to, speech therapy or physical therapy or occupational therapy, that those therapists can come into the home, which could help reduce some of the burden. But again, it's all about qualifying, right? It's all about having the right criteria so that insurance will pay for it. And certainly, again, same thing with respite support. Certain individuals do qualify to get some respite support. But I think, Michele, you brought up some really important points to remember, that could actually increase stress. And I don't think, as healthcare providers, like I had necessarily thought of that side of it, that it could be
Mm-hmm.
stressful to have strangers kind of coming in and out of the house at different times, and it might not actually meet the purpose that we're hoping it meets when we make that
mm.
recommendation.
What, when you both are talking about insurance now, like would, would this insurance be applied to if the family has some insurance to cover these expenses, or is it a state insurance, or both? Like, would the state cover respite care, a 100%, or is it 50%, or or is it?
So I know federally, my dad eventually qualified for permanent disability, so he got a small stipend every month, for my mom, to use towards his care. But his insurance, I don't know that they would cover respite care, actually.
Yeah, that's the hard thing with the United States is that there's, I mean, so much private insurance, and every insurance company does it a little bit differently. And so, again, folks who might qualify for permanent disability, or by age, they might qualify for Medicare. And then we have Medicaid based on income level and ability. Those would be the more federal programs, but everything varies. And so, that's also hard as a health professional, is just trying to stay on top of like, okay, what insurance do you have? What's allowed? I mean, it even varies. I used to laugh when I worked for a university hospital healthcare system. And our insurance, if I had needed speech therapy, our insurance covered, basically an evaluation and maybe 7 sessions a year. And that was me as a speech pathologist. The insurance I had would give me maybe 7 sessions a year without having to go and make a strong case to ask for more. And so it's, the variability is so wild across different insurances.
Is there? I mean, just thinking about trying trying to find out all this information about insurances coverage. Is is there a one point person that would be able to support? I mean, to help to help the family maneuver all this maze just to get some information.
What's your experience, Michele, with that? I can only chuckle.
I do think
Or would or would I refer everybody who's interested in finding out to Michele now?
Yeah, Michele will be the point. Anyone who's listening
The
to
point
this,
person,
reach out to Michele.
it'd be fun. So I think case managers in the hospital do a really nice job of, at least preparing families for what I would consider to be honestly a battle with insurance typically, which is kind of an awful thing to say, but case management really plays that role in the hospitals and in the skilled nursing facilities, because they really can tell what's covered and what's not. However, unfortunately, I don't really think there's that many advocates in that realm. So I know, like, the billing for dad after the hospital, it was like we would get billed twice for things. There were things that came a year later. Like, it's not very efficient, is kind of my personal experience. I think what's nice is, as a provider, especially in the hospital setting, most of the time things are covered within their hospital stay. So, but we do, as providers, I guess I should back up. Medical necessity is something that's really important to consider in our current health system. Um, so, there have been times where I will go to talk to an individual about their swallowing, and they are able to make their own decisions. And, they basically say they have no desire to modify their diet or change anything about it. So I don't necessarily know that would be, that would necessitate an evaluation then, because, people can make their own choices too. So, so in our current system, I think medical necessity is a big thing for us, just because the insurance drives a lot of people's care here, unfortunately. And Samantha, I don't know if you know, but I don't think there's great point people to support families with insurance. So kind of going back to that.
Yeah, sorry, Michele. I was just going to say there's not. And I think another terminology that we have to throw out there then is health literacy. And I think, a lot of families don't have high health literacy. And that then makes it even more of a struggle. And so you're right, like bills just start coming, and then they don't know, like, what am I supposed to do with this? Do I have access to these services? What are the things that my health providers are telling me to do? How do I go about and do that and not have to pay so much out of pocket? And so I think in some of the hospital setting, certain, large, maybe a university, outpatient healthcare setting, again, there might be a point person who is the billing specialist, but often people are left trying to figure it out on their own.
You know, correct me if I'm wrong. Now, the states, the states has has have public and private hospitals. Am I right? Public and private hospitals.
There, yes, and
Okay.
Profit and not for
So
profit healthcare
like
facilities.
as Michele mentioned earlier, that sometimes I mean the family had to bring the father to the hospital for emergency. Would that impact somebody who doesn't have sufficient funds for the private, or would that cause more stress, like the delay of getting services? Can you comment on that?
Yeah, I can. I certainly, at a minimum, concerns over insurance will delay folks from seeking care to begin with. And I think we see that often. Folks will use the emergency department as their primary source of accessing healthcare. And it's only when things have escalated to that level. And so I do think that not having adequate health insurance can definitely complicate these situations, because people aren't even reaching out for care to begin with until something is a major issue.
Mm-hmm. And that adds more stress on the overall situations. But Michele, like listening to you, we have a term within long-term care called the sandwich generation, and more often now we hear about the sandwich generation, which consists of adult children, much like yourself, with your own family, with your own families, career and other responsibilities, acting as caregivers for their parents or parent. What are some of the unique challenges they face and supports required? Because I'm thinking now that we're when we worked in when I worked in long-term care, you know granted the I mean the loved one was in a long-term care facility, but but before admission, they were so stressed out trying to manage their own careers, families, responsibilities, and it is great to, the great it is great to listen to you, Michele, that that your family was very fine tuned, you're really close knit, but it takes its toll, I'm sure, trying to manage it. So, do you have any comments about that?
It's interesting. Um, we as a family, and this could be unique to us, but I think some of those things are less talked about. Some of the factors that go into caring for a loved one. But I can say, so I have two siblings. Um, and, things like personal life, like dating and some of those things. So, I think so it's been 2 years, 3 years since dad passed. And we now, in the last 3 years, like are all in committed relationships. Two of us are getting married. It's almost like there was a pause button that was sort of pushed, and we've moved forward with our lives. I bought my first home. I think there just were things that perhaps we were waiting on, or that were kind of in the back burner. And, I have made decisions career-wise at times. So I actually took a permanent job here in Eugene, and I was doing travel therapy prior. Um, I think partially subconsciously because I knew Dad was not doing well. And there's just been different times in my life, yeah, where we prioritized his needs above our own. A lot of times, I would say. Um, and I think socially, it's interesting to be younger and caring for a parent, because people don't necessarily get that in their 20s. That's not their focus if they're not in that situation.
Mm.
So um, there were times, I felt like I would be in social situations and I couldn't really relate to the people around me just because, you know, their their specific needs or things that were making them upset in life were just so different from my own. So I think those types of stressors are actually kind of interesting. But I definitely think, I don't have a ton of ways to quantify it, but like I said, I can say that my family, it was like now we're just living like a lot of the big life events exponentially faster, I think, than, the 20 years prior. So it's kind of interesting to watch in our case, but um,
Mm-hmm, mm-hmm. This, as 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 I mentioned before, we had lots of questions for you both today. Lots of questions, but just just a few more. When a care recipient needs transition to long-term care now, is there a support program in place to support the care recipient, caregivers, and their families? I mean, this is a huge emotional step for all families to make that transition from community, no, no matter, because as I was saying, I worked in long-term care for 30 odd years, and the city of Toronto it has 10 long-term care facilities, and I still consider them the Cadillac homes. I'm not biased, of course, but they're the Cadillac homes. But work with families to making this transition. Is there any supports out there in the States for that, or is this a gap as well? Or
Yeah, I don't think there's, again, like with a lot of the other pieces, I think it varies facility to facility. There are no specific supports in place, and I think too, we also don't talk about that. I think transitions are a part of the care trajectory that are often overlooked, because I do think transitions come with a lot of increased emotion and stress that we aren't recognizing as part of the situation. And I even think, for example, that transition to a long-term care facility or a skilled nursing facility, for the individual who needs care, it's huge, right? I mean, suddenly they're going from having this more independent lifestyle to being dependent, to maybe even seeing themselves in a different light. Like, oh my gosh, this is a huge uprooting of my life, a huge change of my life. I can also see from the caregiver perspective, there's going to be a lot of conflicting emotions, because on one hand, it's that this is going to be a huge change, this is a huge difference. And then perhaps some guilt about saying, I'm not going to have to manage the day to day aspects of care anymore. And some guilt over perhaps feeling a little relieved at not having to manage those day to day aspects of care anymore. And I don't think we do a good job with transitions. I don't think, as healthcare professionals, we don't even do a good job of communicating with other healthcare professionals at those points of transition. So, for example, as someone is going from the hospital to home, or the hospital to a nursing facility, or home to a nursing facility, odds are they're seeing clinicians at each step in that journey. And yet those clinicians never have an opportunity to communicate across those different steps. And so it's almost like, if we can't even communicate with each other, how are we doing at supporting families through these very crucial moments? And so I definitely think that's a big gap that we need to
mm-hmm,
work on.
mm-hmm.
And I see you nodding,
yeah.
Michele.
I definitely think a lot of the advocacy falls on families still. So, um, there are times where I feel like records don't carry over from the hospital to long term, and families are the ones stepping in saying, well, wait a minute, they were on a pureed diet at the hospital, where is that reflected here? So I think a lot of it falls to families. And my heart always goes out to those that don't have family nearby, or, to advocate for them, just because, um, I just think it's really unfortunate. And um, yeah, I always worry about their care. Like, I hope that someone is advocating for them. But
Mm. Michelle, during your experience, did you know did your family ever have conversations about long-term care, and at what points, or
so I should clarify. So my dad was a timber faller. Um, so I would say he was feisty to begin with. So I'll preface this. It was actually recommended that he go to long term care after the hospital. Um, the healthcare provider said there was no way my mom could handle that and three kids, and um, but she made a different choice. So I think she knew him really, and I don't think he would have been very successful in long term care. And really, quality of life wise, I think we made the right choice for him. There definitely was a lot more caregiver burden, with all of his care needs, obviously at home compared to being in long term care for us. But I think Samantha's right too, kind of the guilt of that, like putting, my
Mhm.
mom was just saying she couldn't imagine having him in long term care and then we would just go visit occasionally, for the rest of his life. She wanted him to be a part of our lives. So, um, and then, as he aged, I would say, and I was having conversations because I was concerned for my mom's health, just because his care was getting to be too much. He had had a fall and broken his clavicle, and there was concerns then, that maybe he was going to be too much for her because she was aging as well. Um, so we did have those conversations, but there was a lot of, I would say, like guilt and shame kind of surrounding that. And again, I do think it would impact my mom's identity, to kind of, um, and we didn't want, quality of life wise, it would be a really tough decision for families, I'm sure, just because, in our case, we
Mhm.
were fortunate enough that we had the means that we could do it and take care of dad. Um, but I mean, if medically he'd gotten to a point where we couldn't, I think we all probably would have been devastated. Just because it would feel like we were just sort of like outsourcing him to someone else. So
Abandoning.
yeah,
Yeah,
yeah, abandoning is a better word. Yeah.
I know. Yeah, yeah. But you're you're right, Michelle. This would be all part of the grieving process. I mean, just to transition your loved one to a long-term care facility is a huge emotional um, grieving process. It's a loss. It's a loss, and not only is transitioning to a long-term care facility, but seeing your father deteriorate as well at
And I
home.
think
It's a loss.
I
It's a
think
toll. It
that
takes a toll.
I think too, it goes back to values as well. Like my family, just my family unit, very much, you take care of your own, and they've always been that way. And so, my mom then took care of her aunt when she was passing, and her parents, and that's just our family's philosophy. So I think there would be a lot of shame just in our family unit if we would have, had to make a
Mm.
different choice. And again, I totally recognize that, it was our privilege to be able to do those things. And I know not every family, can make the same choice. I obviously see it every day at the hospital. So I'm not naive to that. I do want to say, for those that do have to make that choice, like I completely understand everybody's circumstances are different, and we had a lot of privilege in that way. So
Thank you. Now, in preparation for our meeting today, members of the Some Stutter Law team met last week to discuss Dr. Shune's recent article, Contributors to Post-Stroke Dysphagia-Related Caregiver Burden. We came up with all sorts of interesting questions for you, Doctor, and I wish we had more time to discuss them all. First from Laura. Laura is a member of the Some Stutter Law production team, and Laura is a soon-to-be speech-language pathologist. Here's a question regarding the methodology you use. The article notes that participants included in the study were selected if they were participating in meal times by consuming at least a portion of their nutrition orally. So Laura is wondering now, what is behind this decision, and wouldn't this exclude more extreme cases of dysphagia? And the second part, do you think the more extreme cases would contribute to a more significant caregiver burden?
Yeah, thank you for that question. So, for the specific study that you all looked into and we're talking about, we did purposely want to exclude some of those more severe cases of dysphagia. So, if an individual is receiving tube feeding, they may not be participating in the mealtime process. So they might not be sitting there with their family during dinner. Some individuals still choose to do so, but other individuals, if they can't eat, they may not want to participate in that. And so we wanted for that study to specifically look at individuals who were participating in meals with their family. So that almost seemed like the cleanest way to do it. The question about the more severe cases and how that might impact caregiver burden, there have been some suggestions that it could go either way. So certainly if someone is on tube feeding, that can be really burdensome on the family or on the caregiver. That you have to remember, when do I have to do the tube feeding? How do I keep everything clean? How do I prevent infection? How do I make sure we have all the supplies we need? And that certainly can increase the burden. On the flip side, for someone who's so worried about their loved one being able to get appropriate nutrition when eating by mouth, having a tube might actually lessen some of that burden because they don't have to worry about the nutritional side of it. They know that their loved one is getting an appropriate amount of nutrition. And so I think it could go both ways. We're not entirely sure because it hasn't really been looked at much yet.
Thank you. Now, Luca, Luca is also a member of the Some Stutter Law team, and Luca is also a Memorial University linguistics student, and Luca is interested in how speech-language pathologists can help with in intervention. Specifically, how do you prepare families and family members to modify food textures at the home? This may be a question for you both, Michele and Dr. Shune.
Yeah, I'll let Michele. I think you can go ahead and start with that one. That's a good one to send to you.
So a lot of it is education, and I would say definitely meeting the families where they're at. So I think that is actually something that can be challenging in healthcare, is the amount of time that you're given to do some of these trainings. But really, we often give handouts and educate families on the why, like the rationale. So a lot of times if we're modifying textures, we've done some sort of instrumental swallow study, like a modified barium swallow or a fiber optic endoscopic evaluation of swallowing. So, really reviewing those images with the family and explaining kind of the why behind the modification in texture, and involving them in the process, I think is really important. So, you wouldn't want to put a patient on thickened liquids if they're not going to drink them. So, really involving the entire family as a way to educate and hopefully, be able to model those foods also at the hospital. So the kitchens actually bring whatever texture they're on, and being able to kind of show the family the difference. I know with ITSE, we've changed quite a bit in that there are examples of how to mash the foods and there's ways to show those things. Um, so I think those are just a few thoughts I had on educating family.
Yeah, and I'll just to
Michele, this no, go ahead, doctor.
So, yeah, sorry about that. I was just going to add, so Michele had mentioned IDSE, which is the International Dysphagia Diet Standardization Initiative. We have so many acronyms, I think, in our field. And I think it is a great way, too, to have other resources out there. So they have a wonderful website that family members, professionals can turn to get more information. But I think, one thing I wanted to emphasize was Michele said, having a conversation with families. And I think that is a crucial piece that's often missed in healthcare, that we don't ask family members, what do you need? How are you doing? Does this make sense? What have you retained from our conversation? Making sure to follow up with them, because I think healthcare providers often are so used to just bombarding individuals with information and giving, more information is better, without ever checking, are you handling this information okay? Are you understanding what I'm saying to you? So I think that has to be a big piece of it.
This is another question from Luca. Do patients, caregivers feel like they have access to appropriate foods? Do you always have access, or do you have to send off a request, like a menu?
I think access can be a big issue for some individuals. So I think when we, for example, if a recommendation is made to thicken liquids, that requires some thickener to thicken those liquids. And so not all caregivers know where to access it. Not all caregivers know what the different options are. So there's certainly, store-bought, commercially available thickeners, but there's also natural thickeners that individuals can use. And so I think that is where education comes in on some of these different options. I also think food access and food insecurity plays a role in this as well. We know that different areas of our country, different areas worldwide, have different access to different types of food and resources. And so I certainly think that's another consideration. And there's some great organizations out there. For example, in the US, we have the Dysphagia Outreach Program that helps families who might need resources and need food products to be able to have easier access to them.
Mm-hmm. You have you have answered Luca's last question, and the question was, how would you help a family having difficulty managing additional costs associated with dysphagia? So you've answered that. Thank you. Now, Dr. Shune, this is a question from Dr. Paul Dedecker, Associate Professor of Linguistics at Memorial University, which you've met already. The article introduced us to the theory of dyadic illness management. It's quite a mouthful for a person who stutters, which is a very interesting and important idea. Can you explain what it is?
Yeah, so the theory of dyadic illness management by Dr. Lyons and Lee really focuses on this idea that our target of interest is the care partnership. So not necessarily the individual who has a disease at that given time, or the caregiver at that given time, but how they're functioning together. And so if we want to focus on optimizing their health and well-being, this theory proposes that there's kind of two realms we need to look at. The first realm is how they are kind of managing the disease. So who's taking on the responsibility? Is it one of the people in the dyad? Are they equally managing the responsibilities of caring for whatever the medical condition is that's going on? And then the other piece of it is how they're appraising the illness. So sometimes we'll see that the individual who has a disease, so say dysphagia, which is what we're interested in, that person may say, oh, I'm doing fine. Like, it's really not that big of a deal. I can eat whatever I want. And then you talk to their care partner, and their care partner is like, oh my gosh, no, it's not going well. They're coughing, they're choking all the time. I'm so scared every time they eat. And so kind of that mismatch between how they're appraising the situation can contribute to poorer overall outcomes. And so this theory suggests that the two individuals being more on the same page in terms of appraising the condition and also kind of managing the condition together will lead to improved outcomes of the care partnership.
Mm. Paul's next question is: Have you experienced care recipients who might be underestimating their condition, the seriousness of it, or is it like a various levels or stages?
Yeah, Michele, you want to start on that one?
I
Michele?
think so. I personally think of dysphagia in terms of grief, often with caregivers. So I think there is a process, including denial, right, that we all go through when we experience some type of loss. And I think a loss or change in function, if you will, I think at times actually it's kind of this theory of ambiguous loss where it can lead it can lead people to go through the grieving process. So for me, I often see this in the hospital, especially if someone's loved one goes from eating by mouth to then not being able to eat by mouth safely. I do think there's a lot of times that the caregivers maybe like there's a mismatch between the understanding of just how much that could impact their overall health. Um, so I definitely think and then we just kind of meet them where they're at and keep giving education and explain things differently, um, and allow people time to process. So caregivers, I think, very much go through their own grieving process is what I would say. Samantha, what would you?
Mm-hmm.
Yeah, and I think on the care recipient side too, there's a lot of factors that can impact how they're assessing the situation. So, for example, common causes of dysphagia include diseases and medical conditions that can come with cognitive impairment. And so, I think when we're working with a patient or client who has perhaps decreased memory capacity. They might not remember when you went over the results of the swallow study with them and showed them that they have actually something wrong with their swallow. Or, they might have attention deficits or decreased insight that they're not recognizing, no, actually, I am coughing every time I drink water. And so there's could be a mismatch there, and they're underestimating the condition or the severity of their condition for sure.
Mm. One last question now. If any of our listeners are experiencing similar like a caregiver experience that Michele you have gone through. Do you have any any advice or suggestions? This is a question for you both. If any of our listeners are also in this role at the moment? What?
I think I wish I had found a grief counselor while we were still going through dad's care. So I'm a huge proponent for mental health supports. And again, the destigmatization of that, right? So for many individuals, I was someone who thought that perhaps I suffered from depression, only to realize that in my case, I truly feel it was grief. So I'm a very different person than I was 3 years ago. And I think a lot of it is just that a lot of the caregiving process can be fulfilling and rewarding, but also really painful. And so it really wasn't until I found a grief counselor that I was able to kind of unpack a lot of those things and understand that it's actually quite normal to feel the things that I felt over the years, including guilt for wanting my dad to be who he was prior to his stroke, but also, loving him for who he was now. I mean, it's a really different, there's loss and grief, and there's kind of all the emotions. So my advice, I think, would be if anyone's experiencing any of that impact as a caregiver, to, to try to get those supports. And I know there's barriers to that too. So, or find a trusted person, that you can kind of vent those things to. I also like the idea of support groups. I think if there is, access to that anywhere in people's area, just meeting other people who've had similar experiences or are going through the same thing, I think there can be power in that. So I think that would be my advice. But.
Thank you.
Yeah, I would completely agree with Michele and just say it's okay to feel all the feels, right? It's perfectly normal to want to be providing the best care possible and to want to feel strong and to also sometimes not feel strong and to feel vulnerable and to feel guilt or shame or sadness. All those emotions are part of the process. And so I would 100% echo what Michele said, that it's okay to tell someone, this is a lot. I'm feeling a lot right now. And I just think that I need someone to talk to about that. And it's not a sign that you're not doing a good job being a caregiver. I think it's the opposite. I think it's taking care of yourself to make sure that you can continue to be a good caregiver, and it's needed.
Well, ladies, thank you both very much for being part of this conversation today. It was really sort of touching and informative, and I'm sure that our listeners appreciate you both sharing your stories. So thank you very much.
Thank you.
Some Stutterla is hosted by Greg O'Grady. It is produced, recorded, and edited by Paul DeDecker, as well as Luca Dinu, who, by the way, wrote this jazzy theme music. Leah Bugden and Alicia Megison command our pages on Instagram and TikTok. Editing assistance was provided by the Labrador Languages Preservation Laboratory, or Labradory, at the Memorial University of Newfoundland. You can listen to or subscribe to this podcast on Apple Podcasts, Google Podcasts, Anchor, and Spotify. Video versions of each episode are found on our YouTube page. Some Stutterla is a production of the Communication Collaborative. Thanks for listening.